Hi, this is Dr. Bethany Murray. I'm coming to you today to talk to you about respiratory system and pharmacology. Take just a minute while I share my slides. Okay, so we're going to be covering two chapters in the discussion today. First, we'll talk about allergic rhinitis and the common cold. And secondly, we will follow that with a discussion of asthma and other pulmonary disorders. So the learning objectives for chapter 39 are to differentiate allergic rhinitis from the common cold, to describe the role of histamine and histamine type 1 receptor antagonists in treating nasal and sinus congestion, to describe the use of intranasal corticosteroids in allergic rhinitis management, to differentiate antihistamine and intranasal corticosteroid use from nasal decongestants, and lastly, to differentiate antitussives from mucolytics and expectorants for the treatment of cough in the common cold or upper respiratory infection. A brief review of anatomy. The upper respiratory tract consists of everything from the outside air down to the laryngopharynx area. The role of the upper respiratory tract is to warm and humidify air that we inhale, to trap particles and pathogens in our environment and prevent them from reaching the lungs. Our sympathetic nervous system has a role to constrict arterioles or blood vessels, but also to widen the airways and the bronchioles and relax the smooth muscle of the bronchioles and airway system. Our parasympathetic nervous system produces mucus, dilates arterioles, and actually has little to no effect on bronchioles or airway status. Mucus is a natural source in the body. It helps keep our airways humidified and is rich with immunoglobulins, which stimulate the immune system to help neutralize airborne pathogens and keep us from having respiratory infections. And there are a number of mast cells that line the nasal mucosa that contain histamine. Histamine is released from mast cells in response to allergens and other perceived invaders of the respiratory system. You can see from the photograph the picture of the nasal cavity, the frontal sinuses, sphenoid sinuses, going down to the back of the throat. We have then the nasopharynx, oropharynx, and on down into the lungs. And then from the mouth, we have the oral cavity, which connects up in the back of the throat with the nasal sinuses. And all of that makes part of the upper respiratory tract. What is allergic rhinitis then? Allergic rhinitis is inflammation of the nasal mucosa due to exposure from allergens. Most commonly, these allergens are things like pollens, mold spores, dust mite, animal dander, or even foods that we eat could be allergens. We can also have environmental toxins like smoke, fumes, and air pollution. This is the reason that as you're working in clinical sites in the hospital, you are not to wear perfumes because they do serve as allergens for some of your patients. Some people have a disorder called seasonal allergy or hay fever. When pollen and spores are higher, they may have intermittent allergic rhinitis that then subsides during the winter months or is lessened during rainy days. Symptoms of allergic rhinitis include tearing up of the eyes, sneezing, nasal congestion, a postnasal drip in the back of the throat, and itching of the throat. What is the pathophysiology or what's happening here? If you look at the top of the illustration, we're using pollen from a flower as an example. Pollen is released into the air. This pollen then is inhaled into the nasal passages. Cells in the bloodstream will release IgE antibodies in response to this antigen of pollen. The IgE antibodies then come down and bind to mast cells in the nasal lining, nasal mucosal lining. These mast cells then will release histamine. Once the pollen binds to the IgE antibodies, you can see in this bottom illustration, histamine being released, and then histamine is actually what causes the allergy symptoms. So in the final illustration of the person, you can see that their nasal passages become inflamed, enlarged, swollen, remembering the 5 processes of inflammation, redness, fever or heat, pain. It may be expressed as itching, loss of function, and edema or swelling. A secondary thing that happens is there is one of the 7 chemical mediators of inflammation is called leukotriene. And leukotrienes also will be released and contribute to the symptoms of allergy and asthma. So how do we treat allergic rhinitis? The treatment is really symptom relief and prevention. This is not an infectious disease. This is a human body response to an allergen. So we want to prevent by removing or limiting exposure to the allergen. And then we can also use medications to prevent the histamine mast cell reaction or the leukotriene reaction. We use 2 kinds of medications predominantly to prevent this reaction from happening. The first are things that are prevent the actual inflammatory response. So we use antihistamines, intranasal corticosteroids, leukotriene modifiers, and mast cell stabilizers. And we will get to those medications a little bit later on today. Then we also have things that are relievers. So once the congestion has occurred, how do you reverse that process? And you can get immediate temporary relief with oral and nasal, intranasal decongestants that are usually sympathomimetic in action. And if that word is confusing to you, it's just another way of saying it mimics the sympathetic nervous system. The sympathetic nervous system provides vasoconstriction, so you can then reduce the vessel size and the congestion in the nasal passages by using sympathetic nervous system stimulants. Okay, so let's look at our first antihistamine. Diphenhydramine has come up a lot in this course. It has many, many usages. It is a histamine type 1 receptor antagonist. It is also a mild antagonist of acetylcholine in the brain, which makes it an anticholinergic medication. In this case, we care less about the anticholinergic effects and more about the histamine blocking effects. The indications for diphenhydramine are allergic reactions and allergic rhinitis. It is used off-label for insomnia and to reduce mild pseudo-Parkinsonism effects from antipsychotic medications. Common side effects of diphenhydramine are drowsiness and dry mouth. The drowsiness is due to the antihistamine effects. The dry mouth is due to the anticholinergic effects. You can also get paradoxically excitement or occasional tachycardia. Those are due to the anticholinergic effects. And in older adults, diphenhydramine might actually cause confusion or delirium. It is a relatively safe product in children and in pregnancy. Okay, next we're going to talk about corticosteroids. If you recall, corticosteroid is a umbrella term for glucocorticoids and for also the sex hormones. So here we're talking really about the glucocorticoids types of steroids. So glucocorticoids or corticosteroids are used orally in allergic rhinitis as a relief for severe and short-term outbursts. So an example of this might be using prednisone or prednisolone 10 milligrams twice a day for 5 days. They're more often used in a nasal spray as a prevention medication. So we have several inhaled intranasal corticosteroids. It is important to note that inhaled corticosteroids are not appropriate for PRN use because they don't provide any immediate release. The medications we're looking at here are things like beclomethasone, fluticasone, and mometasone. You might recognize those as Flonase, Nasonex, and one also called Q-Bar. So these are available generally without a prescription at the pharmacy, and they work by decreasing the secretion of some of these inflammatory chemical mediators. They act on histamine and on prostaglandins. They reduce tissue edema and mucus production, and they produce a mild vasoconstriction effect. So that helps to also relieve some of this swelling and edema by vasoconstricting. Okay, so we have indications for nasal sprays the indication is allergic rhinitis. It takes 1 to 3 weeks to achieve a peak response. So these are prevention and not PRN medications. We will get back to the inhaled version when we talk about asthma in a little bit. Common side effects of intranasal are nasal irritation, some burning, some sneezing after using, some drippage in the back of the throat, giving you a sore throat, or some nasal dryness. There really are no serious adverse effects. If the person excessively uses this and swallows too much, it will absorb through the gastrointestinal tract, and they can have systemic cortisone effects. So what are decongestants and how are those different? Well, decongestants are used to rapidly relieve nasal congestion. They are appropriate for PRN usage. Most decongestants are either oral or intranasal. The decongestants are sympathetic nervous system agonists. So the problem with nasal decongestants are that a person will quickly become habituated to them. And then when the medication wears off, they will have rebound congestion. So you can avoid this rebound congestion if you advise somebody to only use the nasal decongestant for a very short term when they're acutely ill, and then after 2 or 3 days to use it in alternating nostrils, 1 nostril each day, alternating sides, and then to stop using it as quickly as possible. Sometimes I think people believe that because these are readily available over the counter and fairly inexpensive, that they're also very safe medications. But in fact, there are not a lot of side effects to these medications, but you do quickly habituate and then find that you can't really breathe without nasal congestion without the medication. So we're talking about prototypes like Afrin and neosynephrine. These are not on your drug list to learn, but I think it's important that you know that people use these when they have head colds or allergic rhinitis for immediate relief. So the oral decongestants are used, and you do have one on your drug list. They are also sympathetic nervous system agonists or sympathomimetics. They mimic the nervous system. So therefore, when you take an oral decongestant, you're going to get side effects consistent with sympathetic nervous system activation. So you can get tremors, headache, some trouble sleeping, a little increase in anxiety, a decrease in appetite, and an elevation in heart rate and blood pressure. There is no rebound congestion with the oral medications. And we basically have 2 prototypes. We have pseudoephedrine or Sudafed and phenylephrine, which is the generic name. I have put pseudoephedrine on your drug list to learn. It is a pretty potent sympathetic nervous system stimulant. In fact, you can buy this over the counter, but you must buy it from the pharmacist and sign for it, because it is a key ingredient in the manufacture of the illegal drug methamphetamine. Phenylephrine, though, is existent in pretty much every single cold and flu medication that says decongestion on the bottle. You should remember, though, phenylephrine is a sympathetic nervous system stimulant, and you can get these side effects when taking it. Okay, so when we look at pseudoephedrine, it stimulates the alpha adrenergic receptors, causing the release of norepinephrine, and directly stimulates the beta adrenergic receptors. You get temporary relief of nasal congestion or pressure caused by either a head cold or an allergic reaction. Common side effects are headache, dry mouth, tremors, restlessness, and trouble falling asleep. You can also have a slight decrease in appetite. And then serious side effects, severe dizziness, nervousness, or headache. And I would also say that a slight elevation in blood pressure and heart rate. So typically we do advise people with hypertension, especially if it's poorly controlled hypertension, not to take decongestants that are sympathetic nervous system agonists. Okay, so moving from allergic rhinitis into the common cold, or URI, or upper respiratory viral infections. So there are hundreds, if not thousands, of viral agents that cause an upper respiratory infection. Most symptoms will last 5 to 10 days. The average for an upper respiratory infection is about 7 days. Because these are viruses, we don't really have any good cures. They typically are more annoying than dangerous for humans, so there's not a lot of research going into cures for the common cold. Prevention is our best way of dealing with this. We can use barrier protection like face masks and good hand washing. I think it's interesting to note that once you encounter one of these hundreds of viruses, then you will develop an active immunity, a humoral response, a B cell. If you remember from the immune system lecture, a B cell immune response to that particular virus, but you will still be susceptible to other viruses. The more an older person gets, the more colds they've had in their lives, so the more exposure to these minor viruses they've had in their lives, and the less likely they are to get head colds. Also, people who are younger or people who are around preschool programs or children will have more frequent upper respiratory infections. We usually don't want to use corticosteroids like prednisone in treating a viral infection, because oral corticosteroids can actually lower the immune system response and lengthen the duration of the symptoms. In fact, there's really not much need for any kind of corticosteroids. The nasal ones like Flonase or Nasonex, beclomethasone, for example, take 1 to 3 weeks to work. And since the duration of a head cold is about 7 days, they really have no benefit. What you may find a benefit, which is not on this slide, is a complementary medicine called echinacea. Echinacea has some evidence, particularly in research done in Germany and other countries, that it boosts the immune system. It has immune system boosting properties and can shorten the duration of a cold from 7 days to about 5 days, and can reduce the intensity of symptoms. Now, one precaution you need to take with echinacea is that people that are allergic to ragweed or other similar plants may be allergic to echinacea. So what is our prescription pharmacotherapy for upper respiratory infection? We usually have this divided into 3 categories. We have pharmacotherapy for the decongestants and antihistamines that I mentioned before, but then we also have 3 ways of treating cough. So we have antitussives, which are used to suppress cough and the cough reflex. We have mucolytics, which are used to thin secretions or cut through the mucus. Lytic meaning to lyse or to cut. So lysing or cutting mucus. And then we have expectorants, which improve the solidification of mucus to make it something that's easier to mobilize and cough out and expel from the body. So we'll look at each of these 3 categories. So an antitussive is a cough suppressant. They are used to dampen the cough reflex at the central nervous system or level of the brain. So we really, in some diseases, we don't want to dampen the cough reflex. If someone has emphysema, they trap fluid and are at high risk for developing pneumonia, and we need them to cough that out. If someone has pneumonia, we typically need them to cough out that mucus production. So we don't really want to use a cough suppressant. But in the average head cold or minor flu situation, a harsh, irritating cough might become very uncomfortable for the patient and interfere with sleep. So we may want to turn to an antitussives. So we can use opioids. All of the opioids suppress or dampen the cough reflex in the brain and are a very effective cough suppressant. But as we have learned, opioids have their own significant problems. Probably the only opioid that's appropriate for suppressing cough is codeine cough syrup. It is limited to age 18 years and over because of the risk for opioid overdose. So what we do use often is a medication called dextromethorphan. If you buy an over-the-counter cold medicine, and most medications for allergic rhinitis or head colds, upper respiratory infections are available over the counter. So if you buy a medication that has the initials DM, that stands for dextromethorphan, and that tells you that this medication has a cough suppressant or an antitussive effect. Chemically, it is similar to an opioid. In fact, people who have opioid dependency disorder are recommended to not take dextromethorphan. People that take opioid antagonists, if you recall from our lecture on substance use disorder, there are a couple of opioid antagonists, specifically Narcan or naloxone, which is a short-acting emergency use, and then naltrexone, which is a long-acting daily opioid antagonist. So people that are taking an opioid antagonist like naltrexone, if they try to take dextromethorphan, it's not going to have much benefit because the naltrexone will block the dextromethorphan very similarly to blocking an opioid. But otherwise, they're very good for short-term use to suppress cough, especially for that 5 to 7 days when someone just isn't sleeping well at night. Secondly, the most common side effect of dextromethorphan is drowsiness. So they're very helpful to be added to a nighttime cold medicine to assist in sleeping through the night. You can experience some dizziness as well. These do cross the blood-brain barrier to suppress cough. So you're going to have some neurological side effects. In very large amounts, you can have very large neurological side effects like hallucinations or delusions or slurred speech or euphoria or even a lack of motor coordination. There is an abuse potential because of this crossing the blood-brain barrier, particularly in adolescents or adults who have substance use disorder. Okay, so let's move on to the other two ways that we manage the cough, expectorants and mucolytics. So expectorants are used to reduce the thickness or viscosity of bronchial mucus secretions. Mucus flow is increased and better able to be removed by coughing. So they actually have a function of mobilizing the mucus and making it easier to cough out. I will draw your attention to the bold printed second paragraph. You do not want to use an expectorant in a disease where a person does not have an effective cough reflex. So perhaps a stroke, a central nervous system damage that produces a weak cough, asthma, which is a constrictive airway constriction, or any structural problem in the lungs where there's airway constriction, COPD, which is a type of a catch-all phrase for lung disease like emphysema. So we really want to avoid using expectorants in asthma, COPD, or anyone who does not have a good cough. Because what happens in essence is they reduce the thickness or the viscosity of the mucus. And then if the person cannot cough out the mucus, they essentially are drowning in their own fluids. So we don't want to have that effect. We want people to have vigorous, good coughs to start with when we use an expectorant. So the prototypical expectorant is guaifenesin or Mucinex. It is, I put an asterisk because it's not actually on your medication list to learn, but it's an extremely common medication that's added to many, many over-the-counter preparations. You can get some headaches, drowsiness, and upset stomach with guaifenesin. A mucolytic then, on the other hand, it breaks down or lyses the chemical structure of mucus molecules. So it's actually breaking apart the mucus. It makes the mucus thinner, so it can be removed more easily by coughing. So some mucolytics are used in diseases like cystic fibrosis, which is a genetic disease where a person is born without a protein that is responsible for helping mucus to stay thin and flow well. People have poor water, chloride, and salt and build up abnormally thick, sticky mucus, leading to chronic lung infections, lung damage, and usually associated with a shortened lifespan. So mucolytics are used routinely in diseases like cystic fibrosis, but they also may be added to cough and cold preparations. You should recognize the name acetylcysteine or Mucomyst is one of the brand names. Acetylcysteine is the medication that we learned about in the first month of school. It is a reversal medication for acetaminophen overdose or acetaminophen toxicity. It is technically a mucolytic medication when delivered by inhalation. So it can be used in an inhaler for patients who have cystic fibrosis, chronic bronchitis, or other diseases that produce large amounts of mucus secretions. Okay, so I want to pause for a moment here and talk about how important it is to learn to read labels of over-the-counter medications, and perhaps to help our family members and friends to learn how to read labels. So many of our allergy, cold and flu medications are available without a prescription that it's really good for us to be able to interpret the labels. So we're going to look at a couple of sample labels here and talk through what this label is telling us. Okay, so here is a medication that contains acetaminophen, 500 milligrams in each caplet. and diphenhydramine 25 milligrams in each caplet. Now they have told us here the purpose of putting these medications. But thinking from a nursing and pharmacological perspective, what would we expect this medication to do if we take it? Well, we would expect it to relieve pain. We would also expect it to reduce fever. And then because of the diphenhydramine, which we know is an antihistamine, we expect it to have an activity to reduce histamine response or allergic response in people. It has a side effect of drowsiness. So notice how this label identifies the diphenhydramine by one of its non-FDA approved uses, which is as a nighttime sleep aid. So here they tell us uses temporary relief of occasional headaches and minor aches and pains with sleeplessness. Okay, so this is actually a Tylenol PM dose, Tylenol nighttime dose with the diphenhydramine added. If you scroll down, you're going to see that there's a liver warning because of the acetaminophen and severe liver damage if you take more than, I believe it says 4,000 milligrams in a day, which would be 8 pills from this bottle. I can tell you if you take 8 pills from this bottle, that's enough diphenhydramine to make you sleep or get agitated and have paradoxical reactions. So we can also expect that this medication might cause somebody to have some paradoxical agitation, or if they're an elderly person, some confusion. I have found this kind of medication in my parents' medicine cabinet in the past and thrown them away because in general, very significantly older adults, our seniors or super seniors, don't have any business taking diphenhydramine because of the risk for delirium, which is an acute confusional state. Okay. All right, let's look at this one. This is Equate brand, which is a Walmart brand. It says it is a non-drowsy, alcohol-free cold and flu medication. It says that it works for pain, fever, cough suppressant, and nasal decongestant. Well, let's look and see how it does that. So if we look over here on the right-hand side, the active ingredients are acetaminophen, 325 milligrams. And look, this is a liquid, 15 milliliters. It's an orange flavor for ages 6 and over. So we've got 325 milligrams of acetaminophen in each dose. We've got dextromethorphan, 10 milligrams in each dose. And we've got phenylephrine, 5 milligrams in each dose. So we know that acetaminophen is going to relieve pain and fever. Dextromethorphan is going to be antitussive or suppress cough reflex. And phenylephrine is a nasal decongestant that's going to help with breathing and help decongest the sinuses and the nasal passages. But also, then we have to think about what are the possible side effects. Well, the dextromethorphan can cause drowsiness, but the phenylephrine can cause stimulation and insomnia. So this could go either way. They advertise this as non-drowsy. I guess it kind of depends on the person and how they react. Because some people might have drowsiness to this medication, probably not severe enough to keep them from functioning during the day. But if we're giving this to a 6-year-old, we're going to need to use a lot of caution. You can look also over here on the warnings. This product contains acetaminophen, so there's a liver warning. Okay, and then do not use with other drugs that contain acetaminophen or monoamine oxidase inhibitors or some other particular things. Why would it say ask a doctor before use if you have liver disease, acetaminophen, heart disease, high blood pressure? Well, that's because the phenylephrine is a stimulant, a sympathetic nervous system stimulant. Persistent or chronic cough, because we don't want to really suppress the cough reflex if someone has asthma or emphysema or too much cough. Okay, look, we have also a precaution if you're taking the blood thinning drug warfarin, which you all know what that medication is now. So there could be some drug interactions occurring between the dextromethorphan and the phenylephrine and the warfarin. Over here on the left-hand side, you can see that it lists side effects as possible nervousness, dizziness, or sleeplessness, or if your symptoms get worse, or if your fever gets worse, or if you develop redness or swelling. So these could be signs of a serious condition. It says we're not going to give you any advice on pregnancy or breastfeeding. You need to ask a healthcare professional before use. Thanks, guys. Overdose can cause liver damage, and they actually give you the Poison Control Center phone number on this label for overdose. And then lastly, we've got what the dosing is for. This is approved for ages 6 and over, so they tell us we can use 15 milliliters every 4 hours. How much is in a milliliter? It's 325 milligrams of acetaminophen, 10 of dextromethorphan, and 5 of phenylephrine. If it's an adult, they can take twice that. If they're under age 6, it says ask a doctor. So they're not gonna give you any advice for anyone under age 6. Okay, so by now you should be able to kind of interpret this label a little bit better and say, based on these 3 ingredients, here's what I can expect it to do, and here are the side effects that I can expect it to cause. Okay, so here's another one. This is a Kroger brand. It's a nighttime cough and cold medicine. So let's look at the ingredients. We've got dextromethorphan, 30 milligrams. So we've got significantly more dextromethorphan. This is still cherry flavored. It's got 10% alcohol. So we've got some alcohol and some dextromethorphan going on. We can expect this to be pretty darn sedating. Therefore, it's a nighttime medicine. We also have doxylamine succinate. Now, I didn't talk to you about doxylamine, but it's a mild antihistamine. It's actually a pretty safe. If you have it by itself, it comes in an over-the-counter pill called Unisom. And I do recommend this sometimes even to children at the 12.5 milligram dose. It's an antihistamine that has less paradoxical reaction. Why do you think maybe they put doxylamine instead of diphenhydramine? Maybe because we've got alcohol and dextromethorphan, and that's pretty sedating. And if we put diphenhydramine in there, that's going to be really sedating. The doxylamine is a little bit sedating, but not bad. So anything else? There's no acetaminophen in this. So we're not going to find anything about acetaminophen. We're not going to expect this medication to help any at all with pain or headache or with fever. So if you were taking this medication and you had a fever, you're going to need to supplement. You might want to supplement with acetaminophen. If we look at dosing here, it looks like it's approved for age 12 and over at 30 milliliters, which is one dose is 30 milliliters every 6 hours. Anyone under age 12, they're saying, we don't recommend it. So you need to call for medical advice and recommendations. Okay. So I might want to take this medication at bedtime if I have a really, really bad cough that is keeping me awake at night. And also another thing that I might mention is because this previous medication had no alcohol, but this medication has 10% alcohol. You also want to think about a person who has a substance use disorder or an alcohol use disorder, and a person who might be taking antabuse for alcohol, disulfiram, to prevent alcohol dependency. Another thing to think about with this medication is it seems to me that this might be one that would be highly abusable by adolescents. Remember, these are over-the-counter medications, and you don't have to show any ID or any proof of anything to buy this medication. Pseudoephedrine you have to buy from the pharmacist, but you don't have to with this. So an adolescent who's particularly knowledgeable about substances might buy a couple bottles of this nighttime cold and cough medicine and get this mild opioid kind of effect from the dextromethorphan, and then the alcohol, the 10% alcohol effect. It's small, but adolescents. Okay, and then I think this might be my last label I wanted to share with you. So this is a homeopathic medication or homeopathic treatment. You can see the purpose is to relieve sneezing, runny nose, nasal congestion, sudden onset colds, sinus pain, headaches, nasal discharge, sneezing attacks, sore throat associated with colds, and colds with a loss of taste and smell. So it sounds to me like this homeopathic treatment is for head colds and mild head colds and allergic rhinitis. We're not going to recognize any of this because this is all homeopathic treatment, which means complementary medication. Now, some of this I can kind of recognize. Belladonna is an active ingredient in opioids. So belladonna is going to have some kind of opioid-like activity. I recognize allium, that's an active ingredient in onions, so that may be immune boosting. Nux vomica, I don't know what that is, but I assume because it has the word vomica in it, it must be anti-vomiting a little bit. But really, unless you're studying homeopathic medicine, the way homeopathic medicine works is you have microdosing to treat symptoms. So this would not be a medication that I would recommend people because I just am not familiar with the ingredients and couldn't really give them any kind of advice over using this medication. Okay, so the drugs that I gave you for this chapter 39, allergic rhinitis and upper respiratory infections were diphenhydramine, pseudoephedrine, and dextromethorphan. And now we're going to go ahead and take a short break. So this is a good time to put pause on your recording if you need to, and go get a drink or a coffee or have a trip to the restroom. And then we're going to dive right into asthma and other pulmonary disorders. All right, let's look at the learning objectives for this chapter. We're going to describe the pathophysiology of asthma. We're going to describe the pathophysiology of chronic obstructive pulmonary disease, COPD. Sometimes people say disease, sometimes they say disorder. Most of the time, they just say COPD. We're going to differentiate the medications that are used to treat COPD, and then discuss the nursing care of a patient with asthma. So what is an obstructive pulmonary disorder? So technically, asthma is an obstructive pulmonary disorder. It just doesn't have the C necessarily, the chronic daily management. Obstructive pulmonary disorders are diseases that prevent the normal flow of oxygenated air in and out of the lungs. So the air can become trapped and a person builds up a higher level of carbon dioxide, a lower level of oxygen. There's just not a good airflow exchange. So COPD or obstructive diseases are not related to an infectious agent, although a person can develop a secondary infectious disease. An allergen may precipitate an obstruction, or a virus or bacteria or other organism may take advantage of the weakened state of the lungs and cause a lung infection. So we're going to look specifically at the exemplars of asthma and COPD as defined by bronchitis and emphysema today. First of all, let's discuss briefly the normal physiology of the lungs and some definitions. So respiration is the actual cellular process of oxygen and carbon dioxide exchange between the alveoli and the capillaries in the vascular system and the alveoli of the lungs, which is the air system. So we can affect the respiration or the oxygenation of the blood by the health of the alveoli. For example, the disease of emphysema is a disease where the alveoli have deterioration or breakdown. So we're not getting the air exchange butting up against the capillaries in an effective manner. We also can have respiratory impairment or respiratory alterations due to the lack of oxygen in the bloodstream. So there's a lot of causes for that. Red blood cell anemia. We've talked about anemia a couple times before. So if you don't have enough hemoglobin to carry your oxygen around, if you have hemoglobin deficiency, hemoglobin and hematocrit deficiency, you have red blood cell anemia, you're not going to have enough oxygen. You can also have carbon monoxide poisoning as a respiratory illness. So carbon monoxide, CO, not CO2, has a more potent ability to bind with hemoglobin than oxygen, than O2. The carbon displaces one of the oxygen molecules, and an individual doesn't even feel this happening, but will build up carbon monoxide, and they basically are losing oxygen and losing the ability to oxygenate their blood through the buildup of carbon monoxide. You can also have altitude sickness, which has to do with oxygen, low levels of oxygen in the environment. So there's quite a few different ways that you can have less oxygen in the bloodstream. Ventilation, as a comparison, is actually the mechanical process of moving air in and out. So our lungs expand And then we contract them with our muscles, our rib muscles and our chest muscles. And then we relax and they expand. And then we contract them back. And that's the ventilation. That's why we call a machine in an intensive care unit a ventilator, a mechanical ventilator. So it's more about exchanging the air. So the disorders that can affect ventilation include things like asthma, where the lungs become tightened and constricted and unable to expand to pull air in or relax to push air out. So the air becomes trapped. And COPD with the two disorders of bronchitis or emphysema, where the person has inflamed disease or ineffective air exchange. Either the bronchioles are diseased and inflamed, or the alveoli are breaking down because of the emphysema. Then lastly, you can also have ventilation problems that we've talked about before. What was the number one most dangerous effect of an opioid overdose is actually in ventilation. So it suppresses respiratory effort, and the person is not ventilating. They're not bringing air in and out of their lungs. So they actually die of a respiratory failure or an oxygenation failure. You can also get that same kind of ventilation problem with drowning or anesthesia, basically anything that's not pulling air in and out properly, any kind of disease process or toxin that doesn't allow you to move air in and out of the lungs. Okay, so here is a brief anatomy of your lungs. We talked about the very high upper respiratory tract around the sinuses and nasal passages and down into the nasopharynx area. Now let's move on down a little bit into the trachea. We go into the right bronchus and the left bronchus, and then those divide off into bronchioles or smaller passages. Those bronchioles divide down into smaller passages and end up terminating in alveoli, which I always think of as tiny grape-like clusters. And I know that's very simplistic, but the alveoli then is at a cellular level where the deoxygenated blood comes from the right side of the heart, and it passes through and around these sponge-like clusters and picks up oxygen across the cell membrane. So we're picking up oxygen and we're letting go of CO2. And then the blood becomes oxygenated and circulates back into the left side of the heart, where then it gets pumped out to the brain, the heart itself, and the rest of the body. Okay, so that should all be basically reviewed for you. Okay, so bronchioles consist of smooth muscle. We learned a lot about skeletal muscle, the muscles of the arms and the contracting. We have skeletal muscles between our ribs, but the bronchioles themselves are smooth muscle, and they're very responsive to sympathetic and parasympathetic nervous systems. The sympathetic nervous system will activate beta-2. Sorry, I know you've heard this before, this a lot. Beta-2 adrenergic receptors. So let me throw you back a little bit to the neurology lecture where we talked about the sympathetic nervous system has alpha 1 and 2 receptors and beta 1, 2, and 3. So we're really talking about beta 1 receptors being involved in the cardiovascular system, things like metoprolol, which are beta 1 antagonists. So they will antagonize or block the sympathetic nervous system to reduce heart rate, to reduce blood pressure, to relax the blood vessels a little bit, to improve cardiac functioning. So the lungs have beta-2 receptors, and the sympathetic nervous system will activate beta-2 receptors, which actually cause the smooth muscle in the bronchioles to relax. So when the smooth muscle relaxes, it's very tight. And when it relaxes, the airway diameter can increase and bronchodilation can occur. And I've made a note here that it helps me to think of this. Remember, sympathetic nervous system is the fight or flight. So you need more oxygen if you need to run away from a saber-toothed tiger. It makes sense that the sympathetic nervous system would relax our breathing apparatus, would relax our bronchioles so that we can get more air exchanged in and out when we need to run from danger. And we don't need that then when we're at our rest and digest. So the parasympathetic nervous system is our rest and digest. It activates acetylcholine, causing smooth muscle contraction and the airway diameter to narrow. We don't have to take a lot of deep breaths. So as you look at this, you should be thinking about how could we improve ventilation in these chronic, and I'm going to say ventilation, not respiration. How can we improve ventilation for asthma and COPD while we're thinking about nervous system effects? So maybe what we want to do is we want to increase the sympathetic nervous system activity in the lungs and decrease anti-acetylcholine, anticholinergic, the activity in the lungs. We want to increase adrenergic and decrease cholinergic activity. Okay, does that make sense? The other thing that we know is the sympathetic nervous system is a fight or flight. It's a rapid response. It's a boom. So I bet that medications that activate that nervous system are rapid acting. Whereas the rest and digest, you lay around, it takes longer. There's not a lot of urgency with it. So medications that are anti-parasympathetic nervous system or anti-cholinergic are going to not be rapid reacting, not be rapid acting. They're going to be kind of like longer term maintenance kind of drugs. So just thinking about it this way, it kind of, I think, helps you to understand some of the pharmacology of respiratory disease treatment. Okay, so a little brief talk about administration of respiratory medications. So we've got a photo here, illustration of 3 different ways that we administer medications for respiratory disease. Now, what you may note here is when we're talking about respiratory diseases like asthma and COPD, we're not using a lot of oral medications. We can use some oral medications, but remember, if you use an oral medication, it's going to be absorbed and have activity in the entire body. And you may not need that intensive activity in the rest of the body. You may want it to be localized into the lungs. The lungs are very rich with blood. You're going to get a lot of absorption when you use orally inhaled medications, and very rapid absorption, almost as rapid as intravenously, without the effects on the rest of the body or on the brain if it crosses the blood-brain barrier. So you can get a little bit. When it's in the bloodstream, it can cross a little bit into the brain, but you're not going to get a big pound of effect in the brain. So we've got metered dose inhalers. This first picture is a metered dose inhaler. Those often now use a spacer, which I don't have a photograph of that here, but it's like a long tube that the inhaler is attached to that helps to provide more air, kind of disperses the molecules of the medication a little bit better. The middle one is a nebulizer. So the medication, you can't really see the medication. It's actually liquid form. It's put in a little holding container. And then this is attached to a box on the floor, a device, like a humidity device. And so this is for very young children, really helpful. You can just put their mask on. They can sit and watch cartoons or some TikTok videos or whatever while they wear their nebulizer mask. And then we have what's called a dry powder inhaler. So this is one that requires a little bit more effort. You're delivering medications. You have to count, you dial it up. The medication is in the cartridge, and then you go 1, 2, 3, and then you inhale it in. So you can see this might be more difficult for a younger child to do, but this is really, really common for adults with COPD. Okay, so let's talk about asthma. Asthma is a chronic disease. It affects about 20 million Americans. Starts in childhood. Many of you that are watching this video or listening to this recording probably have had an experience with asthma, or someone in your family has had an experience with asthma. The characteristics of asthma is it might be a chronic condition, but the outbreaks of asthma are acute. So you don't have an asthma attack every single day. If you do, you have poorly controlled asthma and you need better treatment. So you have an asthma attack episodically. It's an episodic disease. When you have an asthma attack, you have an acute bronchospasm with breathlessness, coughing, and gasping for air or air hunger. So there's a decreased oxygenation, and a person starts to have an air hunger and an anxiety associated with that breathlessness. You also have an inflammatory response, which triggers the release of histamine and other inflammatory mediators. So this makes it worse. This will increase edema or swelling in the airways. This will increase mucus production. The whole cascade of inflammatory responses makes asthma worse. And then status asthmaticus is a severe, life-threatening, prolonged asthma attack that can lead to respiratory failure and even death if relief isn't sought immediately. So asthma is something that is very serious and does still lead to death, even in children, if it's not relieved. What's the pathophysiology, or what happens with asthma? So basically our figure at the top, our purple cluster is normal, full, plump bronchioles. And then during an asthma attack, everything kind of gets shrunken down and inflamed and constricted. You can see this picture of the airway at the top. You've got a nice open airway. You've got a mucus membrane lining, a mucus lining in the airway. You've got the smooth muscle on the outside, and then you have the trigger for the asthma attack. You get inflammation where the airway starts to constrict, okay, and bronchial constriction, so smooth muscle contracts. Up here at the top, we see the smooth muscle as a narrow band. Down here, it's a very, very large band. We also have inflammatory cells and debris and mucus that are filling up the airway. So the little hole in the middle is the only hole left for air to go through. Okay, so you can kind of see in this illustration that you need some immediate relief with asthma. What are some triggers for an asthma attack and acute bronchospasm? Any air pollutant, tobacco, strong odor, air pollution itself, living near a highway, cleaning fluids, strong odors, sprays, even perfumes that we might wear can trigger an asthma attack in susceptible people. Some asthmas are triggered by allergens, not all, but some, which would be things like pollen from trees, grasses, weeds, or flowers. It can be animal dander. It can be dust mites, mold, mildew. Some asthmas can be triggered by foods or chemicals like medications, preservatives or sulfites, benzalkonium chloride used in cleaning wipes, food and condiments, MSG, monosodium glutamate, shellfish, dairy. A respiratory infection can often trigger an asthma attack. So if a person has a bacterial, fungal, or viral upper respiratory infection, that might be enough to trigger. And then stress, exercise, induced asthma, especially in cold, dry air, or emotional induced stress, which is triggering a fight or flight response in the brain, can also set off an asthma attack. The overall goals for asthma management are to stop the attack, terminate the bronchospasms, and then on the long term to reduce the frequency of asthma attacks. So I think of asthma as a two-part treatment. You have your immediate urgent care, and then you have your prevention care going forward. So for your prevention, you want to identify these triggers, limit or remove the triggers, or use medications to reduce the inflammatory response of the trigger. Okay, so we want to relieve the bronchial constriction and reduce the acute inflammation that occurs. How do we do that? Well, I think I alluded to this earlier. We can rapidly provide bronchodilation by using beta-2 adrenergic agonists to stimulate the sympathetic nervous system. So our prototype drug here is albuterol. It's a potent sympathetic nervous system agonist, and it's delivered in a respiratory inhaled version, and it causes almost immediate bronchodilation. Then we can also use anticholinergics to suppress the parasympathetic nervous system. Now, anticholinergics are not immediate. They're take longer to act. This is a longer, the rest and digest system is a longer functioning system. So which of these two, ipratropium is your anticholinergic, albuterol is your acute bronchodilator. You know, in an emergency situation, which of these two would you grab for first? You're going to grab the albuterol first. You want the immediate bronchodilation effect. Then you're going to follow up with ipratropium on a daily basis. And then lastly, the third way that we address asthma is by using systemic, which means the whole body corticosteroids. We can use inhaled corticosteroids for prevention, but if you're having an acute asthma attack and you need quick relief, then we're going to give you an IV of prednisone or dexamethasone, one of those kind of corticosteroids that are going to act very, very quickly to reduce inflammation and swelling and improve respirations. As far as long-term control, we want to use inhaled corticosteroids like beclomethasone or fluticasone. So these are inhalers. We can also use mast cell stabilizers to help reduce the release of histamine. Another drug that I have put on your medication list is a leukotriene modifier. There are not many of these, but they actually work on another one of those 6 or 7 inflammatory chemical mediators called leukotriene, and they reduce the inflammatory response triggered by allergens. So the drug I've given you to learn is montelukast or Singulair. So Singulair is not a direct treatment of asthma, it's a treatment of inflammation triggered by allergens. And it's helps as a prevention medication. So this is going to be a daily oral medication that people take when they have allergen-induced asthma attacks. We can also have long-acting beta-2 adrenergic agonists, so long-acting bronchodilators. We used to use methylxanthines, which are similar to caffeine. The prototype is theophylline. We don't use that so much anymore. It's an oral medication, and it has some sympathetic nervous system activity, so tremors, shakes, nervousness, okay? And then lastly, you can start using immunomodulators to reduce inflammatory mediators. So if you have long-term treatment of an injection, usually these are subcutaneous injections that oftentimes the name might have MAB at the end. That's an immune system modulator, and you're actually suppressing your immune response to these allergens or these triggers. Okay, so let's look a little bit more at the 3 medications that I put on your list. Albuterol activates the sympathetic nervous system, relaxes bronchial smooth muscle, results in bronchodilation. No anti-inflammatory properties, though. It's used as an inhaler or a nebulizer. It can be IV in an emergency. You can use a PRN and a metered dose inhaler. This is the puffer that people use a lot when they are having asthma attacks or wheezing. Okay. You don't use a long-acting beta-adrenergic inhaler for an acute attack. That would be a prevention medication. Okay, you can develop some tolerance, and increased excessive use can cause your lungs to stop responding to the bronchodilation effects. You can see here that you would expect some throat irritation, but these other symptoms, tremors, headache, dizziness, nervousness, is because a small amount of that sympathetic nervous system drug is getting into the bloodstream and then going to the brain and causing these kind of side effects. Okay, ipratropium or Atrovent. This is your anticholinergic drug. So this is your secondary, not for emergency treatment, but more for secondary or long-term maintenance. It blocks the activity of acetylcholine in smooth muscle, so you have less bronchoconstriction occurring and less mucus formation. Anticholinergics are always drying. They dry up the mucous membranes of the mouth and the eyes and also of the lungs. Okay, so they're used for chronic management. You can see that you deliver them in a number of different ways. It can be used in emergency management, but not as a first-line drug. And the side effects are, what you might expect with dry mouth, bad taste in the mouth. You can also get headache and a little bit of a cough from affecting those anticholinergic, those acetylcholine receptors. Because they're anticholinergic, if a small amount of this is also getting into the bloodstream, and you can get worsening urinary retention. Okay, inhalers are contraindicated. I guess I should say inhalers. This inhaler, ipratropium inhalers, are contraindicated in soy or peanut allergies because soya lecithin may be used as a propellant. So it's important if someone has a soy or peanut allergy that they investigate the meter dose inhaler that they're using and make sure that it doesn't use soy lecithin, soy protein in it. Okay, so we mentioned beclomethasone and fluticasone as a nasal spray, and here we come back to it as an inhaler. So typically now we're using these as inhaler medications, not as nasal sprays. They decrease the inflammation. For inhaled, they're indicated for acute asthma attacks, chronic asthma, or COPD management. IV steroids are best for stopping attacks. So these are not good medications. An inhaled steroid is not going to be particularly helpful for PRN use because it's not going to be rapid acting enough like an IV steroid is going to be. You can see the common side effects of any inhaled thing: dry mouth, hoarse voice, cough, sore throat. But if you want to think back to your lecture we had on antibacterials and superinfections, these medications are particularly prone to causing, allowing superinfections of yeast in the oral cavity. So always have the patient and teach the patient to rinse the mouth and spit after using any inhaled steroid product. Some people use plain water. Some people prefer to have salt water. They feel like they get their mouth cleaner with salt water. Some people just want to use mouthwash. It really doesn't matter. It's more about consistently rinsing your mouth and spitting out after using this inhaler. Okay. The other medication I gave you was montelukast or Singulair. Singulair or montelukast blocks leukotriene, which reduces inflammation and is used as a prevention of allergic rhinitis and asthma that is triggered by allergens. You can also use it for exercise-induced bronchospasm. I'm not very familiar with that, but I am familiar with it being used as an adjunctive treatment for chronic asthma. It's an oral, once a day in the morning, routine medication. It's not used as a PRN. Side effects are pretty minor. You can see that there could be an increased frequency of infections in older adults. But other than that, it's pretty minor, and it's pregnancy category C, or B, I'm sorry. So it's pretty safe medication. Okay, so leaving asthma, talking about COPD. So COPD, chronic obstructive pulmonary disease, is a progressive disorder characterized by recurrent and chronic airflow obstruction. So there might be exacerbations where people have worsened times, but it's not like asthma where you have an asthma attack. This is a chronic deteriorating disease. Chronic COPD ends up in respiratory failure. So it is a degenerative disease for people. Once you start breaking down the alveoli in emphysema, there's no coming back from that. There's no repairing those. Almost 90% of cases of COPD can directly be associated with cigarette smoking and air pollution, living in contaminated air environments. Okay, so initially, so if you want to just imagine a scenario, somebody smoked cigarettes their whole life. In their 40s, they start to develop asthma. In their 50s, they start to develop chronic bronchitis. They have a hoarse voice. Every time they catch a cold, it goes to their throat and their lungs. They get worse. They get bronchitis. They have to go on antibiotics. Maybe they even get cases of pneumonia. And then in their 60s, they start to develop shortness of breath, low oxygen levels. They start to maybe need to use inhalers more, maybe even then progressing in the mid to late 60s to using oxygen all the time, or oxygen PRN with effort, and then oxygen continuously at home. So eventually COPD will lead to respiratory failure because there's really no repair. What our goal of treatment is to slow down the progress and to maintain the optimal quality of life by maintaining optimal oxygenation. Okay, so in the mid stage of chronic bronchitis, you get a lot of mucus production because of this chronic inflammation. The lungs are trying, and bronchioles are trying really hard to protect themselves with mucus production, and this leads to some partial airway constriction. People get short of breath easily. They have a chronic cough, especially when they first wake up in the morning. They may have more wheezing, more poor exercise tolerance, and more likely to have pulmonary infections. When you make more mucus in a body that's 98.6 degrees, you've got this moist, warm environment that can grow organisms quite readily. So people with chronic bronchitis have a lot more upper respiratory infections and pneumonias. Once it progresses to COPD, or emphysema, you've got the breakdown of the alveoli. The alveoli are dilating. Then you have a lot of secondary infections, a lot more risk for pneumonias, and a lot more eventual need to use supplemental oxygen. And so we're using medications now to relieve symptoms and avoid complications. Emphysema medications are essentially the same medications that we use in asthma. So I'm not going to be giving you a lot more of new medications here. The newer inhaled medications are often a combination. So you'll have a bronchodilator, an anticholinergic, and a steroid, perhaps in one dose meter. Or maybe you have two of those in a dose meter, and then a purple Advair on the side, beclomethasone for as your steroid. But typically there are those three categories. There's every day, maybe even twice a day, you use a bronchodilator, an anticholinergic, and a steroid medication. Okay. People with COPD should not be using beta antagonists. So think about that for a minute. We're stimulating the sympathetic nervous system in the lungs. So why would we give a beta blocker for, say, the heart or the blood pressure? Because we're going to be blocking the beta adrenergic system. So it's going to go against what we're trying to do in the lungs. So they're contraindicated to use a beta blocker or beta antagonist drug, or any other medication that can cause bronchial constriction. Also, when we talked about head colds, we talked about mucolytics and expectorants. So a mucolytic breaks mucus up and makes it thinner. An expectorant helps you to be able to cough out the mucus, but people with COPD and emphysema don't have really good cough abilities to get things out. So if you give them expectorants like guaifenesin, the mucus can then collect up in the bases of the lungs and become trapped. And then that will further decrease the ability to respire or to exchange oxygen and carbon dioxide across the capillary membranes with the alveoli that are remaining. So we want to avoid giving them anything like a mucolytic or an expectorant. Okay, so here were your drug tables for respiratory, lower respiratory disease. We have ipratropium, which is an anticholinergic. We have albuterol, which is sympathetic nervous system bronchodilator. We have the nasal spray, beclomethasone and fluticasone, or the inhaled spray. They're both steroids. We have montelukast, which blocks leukotriene and is taken daily as a prevention for allergy-induced asthma attacks. And then we have any of the intravenous or oral steroids, which will help significantly suppress histamine release, reduce tissue inflammation and edema, and can be used in emergency treatments. Okay, so now I'm going to talk about what your homework is for this week. So if you recall, next week we will have a class on the gastrointestinal system, but that will not be on exam number 4. Exam number 4 consists of the chapters over inflammation and fever, the immune system, the neoplasia or cancer, then upper respiratory, the antibiotics, antibacterials, antifungals, antiviral agents. And then we go into the respiratory system, upper respiratory and the lower, so asthma, COPD, and those medications. Okay, so for that exam will come up around April 14th, 15th, whatever week that is. And you will, so I prepared you some different materials to help you study for that, especially because we're going to be having some online classes with the April 8th and 10th class periods. So do your medication tables of these 29 different medications for this unit. Complete your picmonics. Don't forget about your picmonics on your playlist. I check those after the fact and record your score for that. And then by yourself or with a friend or with a small group of friends, I've created 2 study tools. One is you have an optional immune system and respiratory system exam. This is an essay exam. It's 40 questions. They're very short answers. I won't be grading the exam because it doesn't count for points, but as soon as you finish it, go through it, then when you hit submit, then my answers will come up and you'll have the correct, if you will, answers for each of the questions that you submitted. So just think of it more as a worksheet or a study tool that's done electronically. And you can find that in your Canvas quizzes. It's open now, so you can work on that whenever you're ready. The other thing is I've given you a little worksheet. It's kind of a fill in the blank and another way of looking at this. You can print that out on paper and do that. I've given you both the immune system practice worksheet, and I've given you the answer key. But, you know, you really won't learn if you print the answer key out in advance. So try to do the worksheet on your own or with some friends, and then you can go back and look at the answer key to see if you selected the right answers on that or not. So it's just different ways of looking at all the same material, so you're exposed to it over and over in small amounts. Because we're having some online class sessions, we really won't have the ability to do an in-class review session. So these are your review materials for exam number 4. And of course, if any questions come up, we do have that Inscribe Q&A part of your Canvas site that immediately, if you ask me a question, it immediately generates an email to me so that then I can research the answer and go in and post the response to your question. And you can do that anonymously. So please let me know if you're having any concerns over any of this material, or if you have any questions or anything's unclear. And I thank you very much for your time, and I will see you guys back in class. Thank you.